We have been treating multiple myeloma for decades, and we've been recognizing precursor myeloma conditions that do not need to be treated for as long. And we know that clinically we stratify patients as having MGUS when there are not many clonal plasma cells in the bone marrow, or smoldering myeloma when plasma cells in the marrow are more than 10%, yet the patient does not have symptoms. So these clinical categories are very well defined and easy to recognize in the clinic, yet this categorization is being challenged today by a number of factors. One is deeper knowledge of the genomics of the disease, which similarly shows how precursor conditions are different from full-blown active multiple myeloma, except that there is not 100% correspondence between what genomically we think is a precursor condition and what clinically is, meaning that some cases would be classified as precursor conditions from a clinical point of view, but would be classified as a full-blown myeloma from a genomic point of view. So this discordance is what we're working on, and of course the question is whether we can exploit this discordance and we can attribute to the genomic, let's say, categorization a higher predictive value to find the aggressive cancers that have not developed their potential clinically yet. So it's becoming increasingly clear that this is the way to go, and this will be more and more investigated in the future, also because there is a paradigm shift nowadays whereby we are starting to challenge the idea that only symptomatic aggressive myeloma needs to be treated. Of course, it would make sense to treat early asymptomatic phases of the disease where damage has not been done yet, except that until we cannot tell for sure which asymptomatic cases will soon go on to produce damage, it's clinically not so clear that this is an effective path to go down to. A better risk stratification will certainly help these endeavors as well.